this was a trial that was essentially the final trial in the MiST umbrella, which is a precision medicine umbrella for mesothelioma patient. Essentially what we were doing was taking our learning really from the first arm of this umbrella, which was to look at a PARP inhibitor. We saw some interesting data actually in patients with BAP1 and BRCA1 mutations in MiST1. And so the plan was really to see whether we could augment that, and to do that through combination with a immunotherapy agent, anti-PD-1. The strategy, of course, has been tested elsewhere, but in MiST5, what we aimed to do was to really select patients with perhaps the higher chance of responding. We know that patients who respond to platinum-based therapy might have a higher chance of responding to PARP inhibitor, possibly through homologous recombination deficiency, mutation enrichment. That's one possibility. And of course, in ovarian cancer trial studies, we've seen maintenance being offered to patients on the basis of their platinum response. So we selected patients who had relapsed mesothelioma. This is a small phase 2 trial. These patients had greater than 6 months, which is the median for platinum-based therapy, more than 6 months of disease control. They went on to receive Dostarlimab, anti-PD-1 inhibitor, and also Niraparib, PARP inhibitor. The results were encouraging, actually. We had a primary endpoint of 12-week DCR, and that was met. We expected anything greater than 50% to be positive. Patients had 65% 12-week disease control. In terms of their best outcome with regard to RECIST response measurement, we had 16% of patients having a partial response. And overall, actually, disease control was 84%. That was very encouraging. So we think that this is something that in a immunotherapy naive population has efficacy similar to ipilimumab in the volume based on the MAPS-2 trial, at least from the point of view of response. We are doing a very deep dive actually into the molecular correlates, cellular molecular correlates of response. And in fact, some of the data that we showed included translational endpoint involving the gut microbiome. We have previously reported in MiST4, which was another novel combination of anti-VEGF with anti-PD-1. The gut microbiome seems to be determining, or at least is a correlate of response to immunotherapy. And we see that this correlate is actually related to the tumor microenvironment, and possibly modeling the tumor microenvironment, such that where we have our rheostat, our set point of our biomarker set to responders, then we see higher T-cell infiltration, non-cell infiltration. We tested this rheostat, this biomarker in MiST5, and we found that, in fact, there was a significant correlation between the rheostat and sensitivity, suggesting again that microbiome may be having some influence on response to immunotherapy in these